Brain aneurysms, I often describe it as maybe one of the worst tragedy of human race, where you have abnormal weakness of the wall of the blood vessels in the brain.
Is brain aneurysm a hereditary condition, or it is a condition that is caused by several other things?
The cause of brain aneurysm is multifactorial, and when we say multifactorial, it means different things can cause it. The genetic composition of an individual can cause it. Environmental factors can cause it. Female sex is actually much more affected in aneurysms than the male sex, and most of the time, middle age. Aneurysm is actually, especially when it ruptures, it's actually very deadly.
Welcome back to a new and fresh, exciting episode of Health Talks with Dukes. My name is David, and today we are going to be discussing brain aneurysms. And with me today, I have my beautiful co-host,
Precious Kanu.
And today we're going to be discussing, shedding more light on the topic brain aneurysms. And with us today is renowned neurosurgeon, Dr. Festus Ushupidon. Dr. Festus,
Thank you for bringing me to another episodes of Head Conversation with Dukes. We hope that it's going to be an exciting and educative one for our viewers.
Thank you very much, sir. You're welcome. Today we'll be talking about brain aneurysms. Our speaker today will be enlightening us on what a brain aneurysm is, the risk factors, the presenting complaints, why it's an emergency, and also the treatment modalities available. Many people have not heard or they really don't know what a brain aneurysm is until it is an emergency. Hence the reason for today's podcast, to enlighten each and every one of us. So stay tuned, relax, learn and relearn. You're welcome, sir.
Thank you very much.
So, sir, as a way of an introduction, what is a brain aneurysm and why is it mostly called a silent killer?
Yeah, thank you for that question. So, once again, thank you for bringing me here. Brain aneurysms, I often describe it as maybe one of the worst tragedy of human race, where you have abnormal weakness of the wall of the blood vessels in the brain. Okay, so that leads to sudden rupture. Okay, so this is an educative podcast, so we want to say it in such a way that the viewers at home can actually relate with what we're talking about. So it's just like a pipe that has a weak side. So the weak part of a pipe, if a pipe is carrying water and there is a weak side in it, that particular side has a tendency to actually break through and rupture. And that is what happens in brain aneurysm. Sometimes I describe it to my patients as car tires that has a bump, where you have weakness around that part of the bump. So it increases the possibility of the tire rupturing, especially when it's working. And knowing fully well for a live person or a living person, the fact that the blood vessels carry blood 24/7, blood moves around your body, and then one of these blood vessels somewhere in the brain is now having a part of it that is weak, bulging, and has increased tendency to tear. Okay, so that's basically what happens in brain aneurysms. I must also say that while we talk about brain aneurysms happen in other parts of the body, not only brain. Everywhere you have blood vessels passing through. The abdomen, there is aorta in the abdomen. Aorta can also develop a sort of aneurysms. Okay, even some of the blood vessels along our hand, the brachial artery, some of them also can develop aneurysms. But it's just that the ones that you are seeing, both in the abdomen, the hands, they are possibly much more easily accessible than what is in the brain. Okay, so and most of the brain aneurysms, most of them actually, they will not give you, they will not alert you that they are about causing major trouble. They just do it. Okay.
For those of us that are listening at home that have one or two experience with this particular situation, with this particular condition. We'd like to find out if at all these brain aneurysms are they hereditary? Is this something that can be passed down from father, passed down through family history? Is this something that could be passed down? Is brain aneurysm a hereditary condition, or it is a condition that is caused by several other things?
Well, thank you. So it's multifactorial. The cause of brain aneurysm is multifactorial, and when we say multifactorial, it means different things can cause it. The genetic composition of an individual can cause it. Environmental factors can cause it. When we talk about genetic composition, some people are born with some fundamental collagen deficiency. Now, the wall of these blood vessels, they are supported by collagen. Okay, so when there are deficiencies in some of these collagen, they are congenitally weak blood vessels. Such patients sometimes tend to present with what we call multiple intracranial aneurysms. It doesn't just occur in a place because it's congenitally predisposed to it. Like people that have what we call Marfan syndrome, in which you have some genetic deficiency in production of particular collagen lines, and so on and so forth like that. So that could be a cause of it. But there are some other environmental factors, long history of smoking, so it gets to affect the collagen integrity in the wall of these blood vessels. And once the collagen integrity is affected, it's just like the fibers in the car tires are affected. So they become weak at that space. And then tendency for them to bulge out and subsequently rupture sometimes down the line is there. People have also linked it with use of alcohol, So things like those are things that actually can predispose somebody to it. Of course, a silent killer that we call hypertension, because with hypertension, the pressure with which blood is moved in the blood vessels is quite high. Okay, so and you could imagine that if there is high flow of water against a junction of a pipe, it keeps banging against that junction until when there is some sort of local weakness and subsequent dilatation, and then the patient can go on to go and rupture the blood vessels in what you now call ruptured aneurysms. And you see, as a matter of fact, there should be there's subtle difference between what we conventionally describe as stroke and aneurysm. Okay, aneurysms, they are ruptured small vessels, where the wall of the arterioles or arteries are weak. Whereas in stroke, most of them, they are capillary bleeds, So, and that is why when somebody has ruptured aneurysm, the blood that the brain get exposed to is quite large in volume and spreads everywhere, enters into the brain tissue, enters into the surrounding of the brain where we call the subarachnoid space, enters into the water chamber of the brain where we call the ventricles. But somebody can have hemorrhagic stroke, as it were, and it will just be confined to an area of the brain where like basal ganglia and all the rest. So aneurysm is actually, especially when it ruptures, it's actually very deadly. It's actually very deadly, and just like we have said, the risk factors that you should look out for are some of the congenital anomalies. You see people with very long fingers, long extremities, thin long extremities, very flexible bodies. Some of these people are carrying some collagen deficiency. Habits like alcohol smoking in excess, alcohol injections in excess, and smoking, and hypertension, uncontrolled hypertension. Okay, some dyslipidemias, abnormal fat composition in the body. It's also a risk factor to weaken the blood vessel wall, and that can also lead to the dilatation in what we call aneurysms. Okay, uncontrolled blood sugar. It's also part of the risk factors that we should also talk about. Okay, unlike possibly other parts of the body, like I mentioned earlier, that can be brachial artery aneurysms, like can be aortic aneurysms. All those type of aneurysms can also come up when patients are exposed to trauma, like trauma to the arm, blunt abdominal injury. But rarely is trauma implicated in the development of intracranial aneurysms. That's the brain aneurysms. Okay, so I think by and large, those are some of the basic risk factors that I would want our viewers to possibly hear and know about. Oh, there are a lot of them. A lot of them.
All right, thank you.
Okay, sir. Thank you very much, sir. So, like you said, a ruptured brain aneurysm is very dangerous. So, how common is this brain aneurysm?
Oh yes. So maybe a simple question answer to that is going to be as common as hypertension.
Wow.
Yes. There are a lot of people that they will say, oh, they woke up very nicely this morning. They got to the office. They were having discussion during a meeting, just slumped and died. Quite a number are ruptured aneurysms. Quite a number are ruptured aneurysms because it's very sudden onset, sudden like an explosion, like you threw bomb into a village. That is how it happens when aneurysm rupture. Patients will often describe it, for the few ones that survive to get to the hospital, they will describe the kind of headache that they are feeling at that moment as the worst headache of their life. It's because definitely by the time you are middle age to getting to become elderly, you definitely see that you have had a lot of headaches in your life. So when the particular person is now coming to you to say that out of all the headaches I've had in my life, the worst I'm having is the one that just happened. So it's horrible. So we see it often. The patient presents with it. Some people don't come ruptured because not all aneurysms actually come to you ruptured. Some people, what they come with is possibly they are having what we call double vision, we call it diplopia in one eye. Okay, if they look at you, they see double. So it's as a result of that dilatation, or especially in what we call circular aneurysm, that is compressing on some nerves that is around the blood vessel there. So they are not going to allow the nerves to function properly. So when you look at somebody, you see double. So don't wait until when it ruptures. That's the teaching here. If you are lucky to actually have what we call sentinel bleed, or you have recurrent headaches, or you have symptoms that can be called pressure symptoms of the aneurysm, you present to your specialist on time. You are a middle-aged person. You have always been seeing very well. All of a sudden, one of your eyes is seeing double. You discover that your eyelid is dropping down. You are finding it difficult to raise your eyelid up by yourself. That could be an early pointer to saying that you are developing aneurysm in a particular blood vessel region, especially when you know that you have some of the risk factors for developing aneurysm. Use of recreational drugs, not only smoking, cigarettes, marijuana, cocaine, and other.
All right, sir. With the advent of modern medicine and your vast experience now, what are certain types of tests now that a patient or whoever is listening that has a patient, what are the certain type of diagnostic tests that someone that is experiencing these pressure symptoms that you stated earlier, what are the kind of tests that a person can do to be able to find out, and how frequent should a person test for brain aneurysms if he's presenting with intense headaches? And then is there a particular demographic that is affected by this particular condition, brain aneurysms?
Okay, so thank you. So I think I will start from your last question. In terms of, is there a particular demographic? Yeah, female sex is actually much more affected in aneurysms than the male sex. And most of the time, middle age. When we say middle age, I think that definition is 40 to 60 or 64. Those are the people that commonly actually present with aneurysms. And now, what you will see that is peculiar to that middle age is the fact that that is when the stress of life actually beams the full light, at you. That is when the pressure of what you want to be, family, provision, and all the rest. So also that will possibly tilt most people to develop elevated blood pressure, which will possibly potentiate early occurrence of aneurysms. Okay, so we cannot say that you should go and frequently check yourself with a particular brain scan whether you have aneurysm or not. The first step is, which is one of the reasons why Duke's Neurosurgery is doing this educative podcast, is for you to see a specialist when you have things like that. Okay, you see, don't assume that it is malaria. You wake up early in the morning and then you start having a headache on one side of your head, and you discover that you're having watery eyes, you are finding it difficult to see in a particular place, and you just think it's a malaria. And you go somewhere and you use malaria drug, and the headache is not going. At that point in time, you really need to prioritize having a time with your specialist, because the specialists are trained to actually identify the early symptoms. And once they identify the early symptoms, they may ask for some investigations to be sure whether this is aneurysm or some look-alike of the aneurysm. Because the truth is, there are other things that can cause some of these symptoms that aneurysms can also give. And that is why in medicine, you always talk about differentials. When you talk about possible clinical diagnosis, then you mention that there are possible differentials. So, seeing a specialist, and the specialist asking you, you need to run some scan. And, some of the scans, especially that you run, we talk about scans that will possibly analyze the blood vessels in the brain, what we call angiography. It can be by magnetic resonance angiography, what we call MRA. It can be CT angiography, that's computed tomography angiography. When you hear angiographies, those are images that we outline how the blood vessels in your brain are actually looking like. Are they looking normal in caliber, in size? Are they looking tortuous? Are they looking dilated or distended at any point in time? So, of course, there is also what we call digital subtraction angiography, in which case, if there are some aneurysms that possibly evade identification on MRA and CTA, you can ask your patient to do a digital subtraction angiography, which should possibly pick any aneurysms. Of course, don't forget that there are asymptomatic aneurysms. You see, it's not all aneurysms that are actually going to either present with pressure symptoms, or that are going to present with sentinel bleeds or major bleed. Some aneurysms are asymptomatic, that even when you ask for brain scan, because you are looking for other problems in the brain, is when you see them. And their size is quite small, that what you possibly do when you want to manage them is to just monitor them. Okay, so in that case, in that kind of a patient, you just possibly monitor the size of the aneurysm and control the environmental factors that can lead to increase in the size of the aneurysms. Okay, so by and large, I mentioned some of the investigations you could do, but the primary thing is high index of suspicion, early presentation to the specialist, and of course, with the specialist asking you for appropriate investigations, he will subsequently be able to advise you on which way to go, whether to do what we call watchful waiting, or for us to intervene by different methods of treatments that are available to manage brain aneurysms.
All right, so thank you.
Thank you, sir. So now we've listed out the investigation modalities that can be done. So let's say, for instance, we have a patient that came with this presenting complaints, and you did an investigation, the MRA or the CTA, and you found an aneurysm. What management modalities do we have? And are these modalities available at Duke's Neurosurgery and Specialist Hospital?
Okay, so you say management of aneurysms are actually individualized based on the patients presenting, the patients, and of course based on the environment, affordability, and also based on the location of the aneurysm. Okay. So, of course, in recent years, the trend is moving towards what we call endovascular treatment of aneurysms. Okay. So, what has been the long known treatment for aneurysm is what we call clipping of the aneurysms. Okay, in clipping of the aneurysms, it's just like if you have the dilatation like this coming out of a blood vessel wall, then you come with a clip and exclude that abnormal part of the blood vessel wall from the general circulation. Obviously, from doing this, it closes it almost immediately, in such a way that there will not be any blood flowing into uh, into the pouch any longer. However, there are associated risk factors for risk with such procedures. Aneurysm clipping, they are high stake procedure in which you possibly have to try to open the skull, dissect under the brain, because most of these blood vessels, they are under the brain in where we call the subarachnoid space. Okay, so you're going to dissect the brain to reach where those blood vessels are. You should be meticulous enough in such a way that while you are dissecting, you don't end up rupturing or rupturing an already ruptured aneurysms, because don't forget, this aneurysm had even initially ruptured even without you opening the skull. Now you are now opening the skull and dissecting the brain tissue towards the blood vessel itself. So the risk of rupture is actually high. And some of the instruments that you are also going to use to be separating the brain tissue around it can also lead to rupture. And of course, even in the most of the centers in the world with the best of skill set, there is still about 10% chance of intraoperative rupture of aneurysms. Of course, what you now do with the rupture when it happens in the surgery is what will make difference between the appropriate skill set, availability of the equipment, appropriate equipment, and all. So so that's the first stage I'm going to talk about. So management of aneurysm can either be by craniotomy and aneurysm clipping, or by what we call the endovascular surgery. In Nigeria, the endovascular approach is gradually coming up. Some of our guys are trying to come into that space. Some of them will come into the country from outside the country. The facilities is gradually coming up. But of course, it's still, the affordability is still not there yet, because most of the expertise for this and the consumables to be used, they are not actually readily available in the country. But yes, for the craniotomy and clipping, it's done. It's done at Duke's, and we do that frequently with good success stories. Quite a lot of patients have had their aneurysm clipped at Duke's. Again, one of the responsibilities that we have as clinicians is to always lay all the situation bare in front of our patients of the options that are available for their care, and let the patient make informed decision. Definitely, it is not all types of aneurysms that we will say endovascular treatment is the first line of care for. Okay, because some aneurysms with wide necks, they are actually not the best to be treated by endovascular surgery. I try to explain to the viewers about what we do during clipping. So what we do in endovascular approach is that rather than opening the skull and trying to identify the outside of the blood vessel such that we can place the clip there, in endovascular approach you can use a remote part of the body, the radial artery, the groin, and you put in your guide, and then you try to locate the blood vessel that has the aneurysm on it. And then when you do that, you can either deploy a coil into the cavity of this blood vessel. Now, when you deploy a coil there, part of what you are using the coil to do is to block the lumen of this abnormally dilated part of the blood vessel. And when you introduce a foreign material like that there, blood that is passing on it also will stimulate clot formation. And it is a clot formation that now try to seal this abnormal part out of the normal channel of the blood vessel. So from what I have just explained, you see that there is a downside to it. The little downside to that is there is no immediate exclusion of the aneurysm sac from the circulation, unlike what you have in the clipping. So when you deploy your coil, you will need time for the clots to form around it, solidify, and does not allow other free-flowing blood in the system to enter into the aneurysm sac again. You understand? So that is one of the downside that has been documented about the use of endovascular procedure in treatment of aneurysm. Of course, definitely it is less invasive. It is more acceptable to people. If you have a patient and say, I'll crack your skull to go and handle that blood vessel, the person will possibly think twice, because even to cut something from the surface of the skin is a bit difficult, let alone of saying, I want to crack your brain or skull open to go and look for a blood vessel that is so tiny under the brain. Okay, so the other thing, of course, the clip also can get dislodged. The clip that you put here, especially if the closing pressure is not good enough, the clip that you put at the neck of the aneurysm sac can also get dislodged occasionally. Maybe I've seen one or two in my practice. However, there can be extrusion of the coil also back into circulation. For some of our Western and Asia communities that have started endovascular treatment of aneurysm for a while, one of the things they are battling with right now are recanalization of the aneurysm sac following endovascular treatment, in such a way that there will now be another pouch. If just a part of what you have deployed is open up, then another pouch can get created here, and then another aneurysm forms. Or the part of the coil that you have put there is extruded partly into the lumen of the major blood vessel. And when any of this happens, it makes it so complex to treat. They say, because since there is now a partial coil that is partially in the aneurysm sac and in the lumen of the blood vessel, even if you want to come back to say you want to clip, that is a resistance to your clipping, because the coil is already there. So but there are some aneurysms that their first line of treatment that is often recommended is you doing endovascular treatment. Like somebody has what we call anterior communicating artery aneurysms, ACOM. So if there is facility to do it, there is expertise to do it. When such patients come to me, I tell them, because there is a patient that came to me February or March this year, huge anterior communicating artery aneurysms. So the person that referred to me, I told the person of I said, see, this is anterior communicating artery aneurysms. Everywhere, anywhere, you want to first of all tell them that you can try an endovascular treatment. But if you cannot afford to do an endovascular, sure, I'll go ahead and clip the aneurysm. They said, they want us to go ahead and clip. We went ahead, clip the aneurysm. Patient is home back at work and doing well. Okay, so even though the ruptured aneurysm is a terrible news, and most patients actually present very terrible. Some people will say about 1/3 of them will die immediately the aneurysm rupture, 1/3 will get to the hospital and later die, and only 1/3 will survive. So that is the axiom about aneurysms rupture. But you see, the country, Duke's Hospital, some of our other neurosurgical center in Nigeria will now have developed the skill set. They have appropriate equipment to also deal with aneurysms. So aneurysm surgery, even though is a very complex surgery, not all neurosurgeons will do it. It's more often done by neurosurgeons that have subspecialty in skull-base and vascular neurosurgery, So, but it's safe. High risk, but it is safe. Are people doing it? Yes. Are people surviving it? Yes. So Do you have a choice if you have a relative, a brother, someone, a friend that has ruptured aneurysm not to do the surgery? No. Because if somebody had a previously ruptured aneurysm and has refused to seek appropriate care, that person sits on the keg of gunpowder. Meaning that at any point in time, the aneurysm can re-rupture. And a second ruptured intracranial aneurysm is often worse, than the first one. So once there is aneurysm, the possible only way to go is to seek for care. Now, the care you want to seek for now, is there a craniotomy plus clipping or an endovascular treatment? Craniotomy from clipping is available at Duke's. Duke's does not have endovascular treatment at present, but craniotomy and clipping is available at Duke's and is being done regularly. And a lot of patients that have benefited from the skill sets and the modern equipment of our surgeons and the modern available equipment that are in the hospital.
All right, sir. Thank you so much. That was so insightful. Now, let's move on to my own question. Now, my question comes in two parts. Now, for the first part, we're talking about procedures, talking about different types of procedures for brain aneurysms. What does post-op care look like, especially at a neurosurgeon and specialist hospital? What does post-op care look like in the hospital and outside of the hospital after the procedure? Once the patient is done, what does post-op care look like for those that will be listening?
Okay, all right. So you see, that's an essential part. I keep telling my patients that one of the reasons why you come to a center that is renowned like Duke's and a center of excellence for neuroscience is not only for your surgery. It's actually for preparation for your surgery and your post-op care. Okay, because oftentimes what has been deficient in most of our healthcare institutions in third world is the concerted post-op care that you actually push the patient towards optimal recovery. And that is what you get in a neuro center of excellence for neuroscience, like Duke's Neurosurgery and Specialist Hospital, because the nurses are particularly trained, the doctors are particularly trained to also monitor you post-operatively. There are standard protocols that are already existing, that if you have this patient presenting like this, these and these and these and these are things that you are supposed to do. Even if you resume as a new doctor in Duke's today, that is one of those things that you will see. That, okay, so patient presenting with brain aneurysmal rupture should have this and this and this and this done within 24 hours. The patient going for surgery for this surgery should go have this and this done. And then after the surgery, you have neurosurgeons, you have senior residents on rotations, you have well-trained medical officers that are going to come around and say, okay, so these are things for you to do. The nurses are possibly nursed people that have been operated for ruptured intracranial aneurysms or unruptured intracranial aneurysms before. So the protocols of, we don't want you to cough, we want to give you cough suppressant, we don't want you to strain, we want to control the softness of your poo, we don't want you to laugh too much, we don't want you to be too excited, we really don't want you to be under any form of pressure, because within 24-48 hours, we don't want you to have raised intracranial pressure that can possibly dislodge the clip. And if you are waiting for surgery, if you are presented to us earlier enough, we know some of the causes of the bad headaches that patient will have presented with is stemming from what we call the widespread vasoconstriction. So we have medications that will have been prescribed for you even before your surgery to say, take care of the vasoconstriction. We have medications that will prescribe to say, take care of the headaches, take care of the pressure in the brain. So all those ones are already standard protocols. Okay. So, and you see, for most patients, when they undergo craniotomy and clipping of aneurysms, I think if I can remember, the last patient that was operated in the month of April or thereabouts was discharged under 3 days. You see, because once you have craniotomy and aneurysm clipping and the aneurysm is excluded from the circulation, there is nothing that you're waiting for in the hospital. Once we take our precautions of the first 24-48 hours about it. And again, that is one of the reasons why you come to center of excellence for neuroscience, because you see, somewhere else somebody will say, oh, if it is aneurysm, it's a very big surgery. Of course it's a big surgery. You have to stay in the hospital for 2 weeks. You're spending unnecessary money. Once it is done, you go home and then you come back for your follow-up in the outpatient neurosurgery clinic. And you see, those are some of the few things that we keep talking to our people about, we keep talking to our viewers about. The dynamics of healthcare has changed. There are centers in the country now that they are primarily for quality, excellent delivery of healthcare. And we want Nigerians also to stop joining the next flight to the neighboring countries or the far countries to go and access care. You see, everything that you are thinking you are going to access there, they are available. The level of the skill, the level of the expertise, the equipment, they are possibly also available in the country. So, post-op care is top-notch. Pre-op preparation is top-notch. And the skill set for the neurosurgeons, the equipment that are available. The standard of aneurysm surgery is a minimum of an operating microscope. Minimum. Of course, your operating microscope should have different fluorescein dyes that you can use to know whether some of the perforators around the arteries are not taken with your clip. And those are some of the steps that are available, at Duke's Neurosurgery. So as much as we want to be as conservative as possible, not to talk about what is available, but we know that it is also good for Nigerians to know that things are now available in the country. It's so much available, and we really need not only patients now, even the healthcare specialists, even other neurosurgeons should know that these things are possible in the country now. And it's a way to encourage everybody to say that let's join the train of making the healthcare in the country to reach the glorious destination.
All right, sir. Thank you. That was a fantastic answer, a fantastic response. Over to you.
Thank you very much, sir. So, like with the risk, there are risks associated with every form of surgery. So, in patients that have brain aneurysms that are taken to the theater, how common are complications, especially intra-op, and how well do you, explain to your patient before taking them to the theater that these are the complications that can be, encountered, and what can be done, or how do you manage those complications?
Okay. All right. So thank you. So the consent taken for aneurysm surgery is an high-risk consent. You see, like I told you, especially for patients that have come to you, either any category of patients anyway, whether it's ruptured, whether it's unruptured. Like I always tell my patient, I say, you are carrying your skull everywhere, skull intact, not open. The dynamics and hydrodynamics have not been changed. The aneurysm ruptured. Now I'm going to be changing the pressure dynamics by open part of the skull. Then I'm going to go under the brain to look for the blood vessels before I clip it. We have issues. We had had cases in the past of patients that even while they were opening the skull, the aneurysms ruptured. So why I said that is that you should always ensure that patients going for aneurysm surgery has detailed explanation, especially the relatives. Some of the patients going for aneurysm surgery are neurologically poor. Some of them are GCS of 8, GCS of 10, so they are possibly not the people that you can communicate with at that time. Even some of them that you can communicate with, you want to, as much as possible, especially once they are not the one that will sign the consent, to manage the information that you will give to the patient. You will rather give more of those information to the relative, because in trying to now give all the information of, see, there is possible rupture, and when there is rupture, if it cannot be controlled, it can lead to brain swelling can lead to death. The patient, even before entering the operating room, can now rupture.
Wow.
And then it becomes a big deal. So you see, experience, the fact that you should have experience in either talking to the patient and the fact that you've been managing this makes it easy for some of us to actually handle possibly the situation better. So definitely you don't hide anything from your patient. You tell them it's an high risk procedure. Possibility of rupture is there. If the rupture is there, we are set to say that we're going to possibly do what we call proximal control. When you do proximal control, you want to, as much as possible, suck out the blood from entering into other parts of the brain and then eventually leading to brain swelling, and then still try to go ahead and clip. But in the event that the complication is out of control, one of the major intraoperative complications is the patient can actually die. So, but you see, like I said in part of the answering to the questions that you asked earlier, if somebody already has an aneurysm that is symptomatic or that has ruptured, it is either you go ahead and try to take care of the aneurysm, or the person is sitting on a keg of gunpowder. Because if it also ruptures and nothing is done to it, it's possibly also going to lead to an eventual death. But you see, safe. If I can remember, of course, I always say that when a surgeon tells you that don't worry, surgery is very safe. There is no complication at all whatsoever. Don't worry. I always say something that some of my doctors will know. I said it's either the doctor, the surgeon, has not done enough, or the surgeon is lying to you. Okay, so if I sit down in front of the screen, I say, oh yeah, I've clipped a lot of aneurysms, but I've never had complication. No patient has ever died after aneurysm clipping or before aneurysm clipping. You should just know that I'm lying to my viewers, which is not right, you see. So a few of the patients possibly coming very bad, GCS of 6, GCS of 7, 8, brain has actually been deeply affected. Even after the surgery, some do make it out. But does that mean that if you have a relative, a friend, somebody that you know that has aneurysm rupture, should not go for surgery? The answer to that is no.
All right, sir. Thank you so much. Let us paint a scenario now. In the event of a successful surgery, successful post-op treatment, post-op care in the hospital, and now a patient has gone home, are there any significant lifestyle changes that occur before the patient was diagnosed of a brain aneurysm, before he or she started getting the pressure symptoms, the terrible headache? Is there any, or are there any significant lifestyle changes before and after a successful?
Yeah, sure. Actually, I must also drop in that I've had more of successful aneurysm surgeries than the unsuccessful ones. So maybe, but again, a surgeon learn more from unsuccessful operations. So you may actually not be able to count the number of successful ones, but one or two that are unsuccessful, they are the ones that possibly stay with you for a very long time, to come. You keep remembering them, Yeah. So to go back to your question, definitely, when we were talking about the risk of developing aneurysm, we talked about the fact that it's multifactorial and there are environmental influences like heavy consumption of alcohol, smoking, reactive drugs, recreational drugs, hypertension that are poorly controlled, diabetes. So all these are some of the things our patients that have had successful surgery with us should actually look into. So by the time you are leaving the hospital, you must ensure that your blood pressure is adequately controlled. You must go actually stop taking some of these high psychoactive drugs, and all. So the ones that you can control, that are within the limit of your power, you should do it. Well, no, but don't forget that we also talked about some that are genetic and hereditary, like people with Marfan syndrome, people with Ehlers-Danlos syndrome, all those ones you're possibly out of your control, and there may be little or nothing, except if there are capabilities of doing what we call the genetic engineering to possibly remove the gene that is coding for them to have poor collagen. So, but definitely some of those things that predispose you to the risk factors should not be done again. Your blood pressure should be controlled, but if your work schedule, yes, you can go along with your work. No, that doesn't stop you from working. That doesn't stop you from going to your pre-morbid work. as much as you can control your stress.
All right, sir. Thank you so much.
Thank you very much, sir. This podcast has been really insightful. So, as we're getting to the end of the podcast, what take home word do you have for our viewers?
Okay, all right. So aneurysm is common, like I mentioned. Once you have elevated blood pressure, you should try as much as possible to adhere to your drugs, use your drugs regularly, try as much as possible to go for frequent checkups. Don't wait until when it ruptures. And when it finally, if in case it ruptures, make sure you seek a specialist care at a center of excellence for neuroscience, where you're sure that both your pre-op, intra-op care, and post-op care are in safe hands.
All right. All right, sir. That brings us to the end of today's episode. We had a very nice time. It was very insightful, very educative. And we want to say, stay tuned. If you have any patient, if you have any relative that is affected by any of these conditions, feel free to reach out. The contacts will be displayed on the screen when you're watching. Feel free to reach out and be able to see a specialist today, because early detection helps a whole lot more in the outcome. Thank you guys so much for riding with us, for sticking with us, and see you guys next week. Thank you.
Don't forget to like, subscribe, and watch out for our next episode. Thank you.